So I'm just going to give a quick introduction to our speakers. First up, we have Dr. George Gao. He is with us today as the director of the Chinese CDC. His research interests include virus entry and release mechanisms and host immune receptor recognition, and his group research is mainly focusing on virus entry and release, especially the influenza virus, interspecies transmission, structure-based drug design, and structural immunology. He's also interested in virus ecology, especially the relationship between the influenza virus and migratory birds and live poultry markets, as well as the bat-derived virus ecology and molecular biology. He obtained his PhD from Oxford University and did some postdoc work in both Oxford and Harvard with a brief stay in Calgary University. So yeah, welcome George Gao. We're really excited to have you here. Next up we have Dr. Pardon?
My pleasure.
Yay. And next up we have Dr. Racaniello. He is a Higgins Professor of Microbiology and Immunology, and he is a PhD at the Mount Sinai School of Medicine of CUNY. He's also the host of a really interesting podcast, This Week in Virology, and he is a professional virologist at CUIMC. His research interests include work in investigating the role of the rhinovirus replication of cell proteins that interact with the viral 2B and 3A proteins, picornaviruses in wild mice, the interaction of picornaviruses with the innate immune system, and the mouse model of rhinovirus infection. Some of his recent work includes investigating the cell type specificity of and functional redundancy of RIG-like receptors and innate immune sensing of the Coxsackie virus B3 and encephalomyocarditis virus. He's also worked on the replication of the early and recent Zika virus as it's isolated throughout the mouse brain development. Thank you so much for being with us here today. We're going to be just providing the angle on virology and stuff like that. So we're really excited to have you here. Last but not least, we have Dr. Robert E. Fullilove. He is the Associate Dean for Community and Minority Affairs, and he is a Professor of Clinical Socio-Medical Sciences and the Co-Director of the Cities Research Group. He's authored numerous articles in the area of minority health. From 1995 to 2001, he served on the Board of Health Promotion and Disease Prevention at the Institute of Medicine at the National Academy of Sciences. And since 1996, he has served on 5 IOM study committees that have produced reports on a variety of topics, including substance abuse, addiction, HIV/AIDS, tuberculosis, and damp indoor spaces in health. And in 2003, he was designated a National Associate of the National Academies of Science. So welcome. We are super excited to have you here today. Just to give a brief overview of how this event is going to work, I see a lot of people are here with their cameras and microphones turned off, so that's great. So for the remainder of the meeting, what's going to happen is that we have a list of questions that the CSR team has prepared on what we'd like to ask each of the speakers. If any of the audience members have questions that you'd like to ask, please go to the chat feature and send it in the chat either to me, Catherine Wu, or one of the other co-hosts. And in the remaining 20 minutes of the event, we will get to asking them. So first off, we're going to start, well, first of all, there are 3 areas we're going to be covering today: the medical aspect of COVID-19 public health, the social aspect, the public health aspect of COVID-19, and also the social implications for the governmental side of it. So for example, the Chinese government, and also the optics of how COVID-19 has interacted between China and the US, etc. So I'm going to get started with a question that I'd like to pose to all of the speakers, if you'd all like to weigh in. How does COVID-19 compare to epidemics and pandemics we've seen over the past few years from the perspective of your field?
Well, I'm the public health guy. How about I begin first?
Okay, sure.
Clearly, COVID-19 is something that is completely unprecedented. We have been warned that at some point in time, the world would be basically challenged by the creation of some sort of pathogen that would take advantage of all of the elements of civilization that facilitate the transmission of a pathogen like this. But over the last couple of years with SARS, with MERS, swine flu in 2009, 2010, we've had waves of viruses pass through the human systems of togetherness and what have you, but we have never seen anything that was quite as dangerous as what we're seeing now with COVID-19. because the mortality that is associated with it is exactly the kind of thing that overwhelms the systems of healthcare in just about every nation in the world. So although it's increasingly appearing that it's not quite as deadly as we feared, the problems that it does create for the health system and the numbers of people who require hospitalization are completely unprecedented. There are swarming large systems of health throughout the world, Italy, New York City, you name it. And it's one of the things that makes this a completely unprecedented and very unusual event in the history of epidemics in the United States. The only thing that comes close is the 1918 Spanish flu epidemic, which was slightly different, but which was certainly quite deadly, and our first real modern day intervention in which the viral world impacted the modern world and terrible things happened. Let me stop there.
Thank you.
May I?
Yes, feel free to weigh in.
Okay, for this kind of question, I was asked, even from the very beginning. This is a very unusual virus. This is a very unusual pandemic. I think you can only imagine this pandemic can only be comparable with 1918 flu, or even with Black Death, all those kind of pandemic, or with smallpox. So totally, if we are in the 21st century, we never see this for centuries. Now think about, like Dr. Fullilove said, swine flu, avian flu, SARS, MERS, compared to the COVID-19, they are just small potato. It's too small. I mean, you compare with this one, you don't want to mention it. It's totally different. We have been expecting some virus like this. I use the word expecting because of the climate change, because of the human behavior change, because of so many things, ecology change, and we think there might be a virus is coming, and also we as a scientist working in this field with a lot of my colleagues from the US, UK, France, and everywhere in the world, even Africa, everywhere. I have a lot of friends there. I've been involved in so many committees and boards. We are thinking we might have a virus like this one coming, but we never thought when and where. So obviously, this is the virus. When it comes, it came. That's it. So we are expecting, or we are thinking there's a virus for pandemic. Either it could be flu-like or flu itself, or coronavirus. So it's not a surprise you have a coronavirus behaves like that, but it's really surprising. The virus behaves like that, this one at the moment. The virus, why I call it unusual? This virus has a lot of hidden characters. For example, like Dr. Fullilove said, and the virus just suddenly, it looks like from a very beginning, for example, in New York, in Wuhan, and in Italy, looks like it's, it's so quiet. So suddenly, it's exploded. And like you have a fire in a building, if it's SARS or MERS, you would easily recognize whose room is initiated this fire. For this guy, initially you thought, okay, that's a very safe building, and suddenly the whole building on fire, but it's very difficult for you to recognize which room. This is exactly what was going on, what happened with this particular virus. So this virus has a lot of hidden characters. So this is why I'm calling all the scientists in the world. We got to work very hard to understand this particular virus. Otherwise, in the 21st century, we wouldn't have a virus like this one as a pandemic. Somehow, we have MERS, SARS, swine flu, and compared with this guy, it's so easy for you to understand. It's so easy for you to get it controlled, get the virus down. But for this one, we've been working so hard in the whole world, from China, US, and the UK, Europe, and even now it's Africa. And a good example in Asia, Japan, Korea, and also Singapore, and now it's in India. So we know we try to use all the measures, all the strategies we could, and still look like step by step from one country to another. So it moves like that. So some example I give you first, asymptomatic infection. So many cases, they are asymptomatic infection. So it's very hard to get those asymptomatic infection controlled. But some cases, it's really severe. So it's suspected maybe this virus, initially, they turn down or shut off your immune system and your cells function. And then suddenly, the virus will rebound and they'll come back. They just stimulate your immune system. And then you have a cytokine storm. Not like the flu, not avian flu, not like the SARS or MERS. They might be shut down a little bit, but not that hard. And they always came up with cytokine storm. But this one, for some death cases, severe cases, you will see the cytokine storm. But it's not that clear from the very beginning. Anyway, I just start with this. We can have a discussion in detail later. So that's my general comments about it. And Kathy, you asked this special question. Conclusion, this is unusual, covered, and very, very special virus we are facing. Thank you.
Right, thank you.
Well, pandemic is a rare occasion. They don't happen very often. There's this one, and I think everyone's forgotten that we're in the midst of another pandemic at the moment. Please don't forget HIV/AIDS. 37 million people infected. I think that's pretty stunning. And that is even more insidious than SARS-CoV-2. And then we go back to 2009, which was a rather mild flu pandemic. 1968, before that, was rather serious. Maybe most of us don't remember, but it was 57. And 1918, as was mentioned, of course, a huge one. But this, in my view, this could have been prevented. It's shocking to me in our society with all its technology and the science that's terrific, it could have been prevented. That, to me, is the most outstanding feature of this virus. You've heard things like, it's stealth mode. It causes so many inapparent infections or mild infections. It spreads silently, and that's certainly an interesting feature. And all those are unique. The fact that there's no population immunity is amazing. But to me, it could have been prevented. We have the tech to prevent it. No one wanted to do it, or at least no one involved in making vaccines and drugs wanted to do it. And I hope we learn a lesson for next time. I hope this virus teaches everyone a lesson.
Thank you. I think we can definitely all agree that COVID-19 has been really unprecedented on many fronts, including its hidden characteristics. Thank you also for bringing our attention to HIV/AIDS. Our second question for the medical aspect of COVID-19 and the situation is, what is each of your understandings on the state of vaccine development for COVID-19? Or more specifically, what do you think are the resources most urgent to finding a solution to this problem as of now?
The public health solution in the United States is very obviously to follow what's happened successfully in places like South Korea. You've got to test because we have to know how widely spread this virus is. You've got to be clear about the patterns of transmission. So at some levels, you've got to do some contact tracing. In places like in New York City, where you've got heavy concentrations in communities that have already high rates of health disparities, including, for example, HIV, you've got to be really clear that you're not only going to have to do the contact tracing and the testing, you've got to deal with a community that is very upset about the way in which the management of COVID-19 has been handled. This is the set of communities that have suffered the highest levels of mortality. They've often been the folk who had the hardest time getting tested or getting access to care. They're also the folk who are probably most essential for the running of New York because they are the public-facing workers who have to keep the city going. But because they're the folk who are driving the buses, running the trains, serving you food, managing all of the things that have to do with keeping a city like this running, basically the biggest problem is going to be to figure out how to protect them so that if there are successive waves of the virus, we don't suddenly have the entire workforce, including our medical and public health workforce, suddenly ill and unable to care for the general public. It's going to take at least a year and a half for an appropriate vaccine to be rolled out and available to the general public. There's no way to rush that. There are a few candidates that everybody likes, but in order to really make sure that the public is protected, that you don't put a market, you don't market a substance, a molecule, a medication that is simply not going to work, there's got to be a lot of time in which it's tested and monitored before we're actually going to be okay that it's safe. So probably the thing we're going to have to do is have a better handle on how quickly the virus is spreading, how many people have it, what we've got to do to control it before we can get to a point where we'll have a vaccine that can help us ultimately, hopefully, eventually eradicate it. Let me stop there.
Thank you.
I do agree. Testing is the key. For this kind of virus, and anyway, in general, for all the infection agents, so you got to identify the source of the infection. That's very important, and then stop the transmission route, and then you try to protect all those vulnerable or susceptible population. That's a text. That's what you were told. You were taught in the textbook. So testing is the key, and isolating any suspected or any patients is also important, and then quarantine the close contacts, quarantine, all these suspected cases. That's very important because this virus is transmitted by droplet. When you are talking about droplet means, either they can go through the respiratory system or direct contact. You are a droplet, maybe it's a droplet, they were, in the your doorknob, something like that. This is why you have to wash your hand. This is why I'm encouraging everybody to wear a mask, because the droplet is there. And also asymptomatic infection. You don't know whom you are talking to. Maybe you are talking to someone who's already caught the virus, but it's asymptomatic infection. That's something, for the current situation at the moment. For the long term, for prevention control of this COVID-19, of course, it's vaccine and special drugs. So looks like remdesivir, it looks like it's already confirmed it might work. So this is a not special, it's a special for all the coronavirus, including MERS and SARS. Of course, vaccine. So everybody is working so hard. All the countries involved, we are working so hard for the vaccine development. There, I would encourage people, I would encourage all the countries, we should share the information. We should share what you got. We share the experience. I don't want everybody to debate, to quarrel, to quarrel something is really irrelevant for the prevention control. We really need, like Dr. Tedros said, solidarity, and solidarity. We need to share the information for the vaccine development. I hope, because we are in the 21st century, we will have a vaccine all over the world. Everybody who is susceptible for this COVID-19 should be vaccinated eventually, as soon as possible. Over. Thank you.
Let me point out a different aspect of vaccines. So there are over 70 in development, which is great. It's great to see all these companies jumping in. They have great technology. And why are they jumping in? Well, maybe some of them want to save lives, but most of them see a profit. And that's why we didn't have a vaccine after SARS-1, because there was no money to be made. And this is the fault of our system that we've developed, a for-profit system to develop drugs that we need to keep people healthy. And we could have had ready an antiviral that would inhibit all coronaviruses, but no one wanted to invest in it. So another thing I think hope to happen after this pandemic is over is that we change our model for developing life-saving medicines. There are a number of nonprofits that have just popped up that are raising money and running drug trials that know industrial entity will touch, and they will have vaccines and drugs ready for the next pandemic to be immediately tested. That's where we should be. And we can't have for-profits calling the shots anymore. Now, I think it's interesting that we have so many vaccines. There will be several of them developed. And I think after a few years, we're not going to need them. We're going to have extensive population immunity, and this virus will be just like the other endemic common cold coronaviruses.
Hey, can I make a comment for that?
Oh, okay. Yeah, sure.
Can I make a comment for Vincent saying about not profitable or not, that's, vaccine development for this kind of virus is not profitable, or, this is why the big pharma, they don't want to do it. Think about what we have here. We should learn a lesson. We should tell all the big pharma, under such a situation, you are losing, billions of dollars. Your investment is really profitable. If you invest earlier, and now, everybody, you are making profit, not only for you, you are making profit for everybody. So I think by the end, with this pandemic, I think all the big pharma really should realize public health issue. It's not his or her own company issue. It's an issue related to everybody. It's an issue because related to everybody. It's also related to that big pharma CEO or chairman. Because once you are here now, you are losing billions of dollars. Thank you. That's my comment. Over.
Thank you all for weighing in. I think what we can definitely take away is that the solution finding and vaccine development is very much a process, and that there are different candidates, but more importantly, there's a collective response needed from the public in order to coordinate a solution to this problem. I think the discussion around the for-profit angle also really opens our eyes to, as to why maybe our current public health model is allowing for a more stagnant situation than could be. So our final and last question surrounding the medical aspect of the situation is that there is a difference across the globe in terms of death rate. For example, where I'm at, I live in Hong Kong and I'm there currently. There's a dramatic difference between the mortality rate here and also the number of cases versus New York. So why do you guys fundamentally think this is, and what main disparities do you think exist between the way different countries are handling the situations? And perhaps Dr. Gao, in your response, being a representative of China, you could talk about the more specific measures China is taking.
You're right. Death rate or case fatality rate, CFR, it's so different from different countries, and also in China, it's so different from area to area. So obviously, that's something with the measures or strategies you introduced. For example, in Wuhan, of course, we have from the very beginning, the initial CFR, case fatality rate is very similar to what you saw in Italy. And but the other part of China, again, it's very important. We call it the 4 early strategy: early, detection, early report, and you need also the early treatment. So once you have something, you report it, and you early diagnosis, you have all this diagnosed, you introduce all the measures, like we said, quarantine, isolation, and the rate will come down. And also, you treat if the patient or any cases they are in the early stage of the infection, you already intervene at that stage. Of course, the CFR will come down. So because from a very beginning, why? Because we have a very hard CFR, because we, again, like what we said, we discussed earlier, we have no knowledge about this virus. But now look at what going on here. The CFR in the whole world, anywhere, is coming down, because we now understand what's going on. For example, as I said, from the very beginning, this is the virus. They shut down your immune system and your cell function, and then you try to improve that, and then you realize suddenly they might have cytokine storm. In this case, you try to introduce some immune suppression. The second stage, you try to get some immune suppression drugs like tocilizumab. The tocilizumab was used in the later stage. So, and also the plasma, convalescent patient plasma, and also, is used. And we also know the virus can last for a long time in the patient lung. So this is why even in the later stage, when you use the tocilizumab, when you use the convalescent plasma, it still works. So I think through the time, because of understanding of this virus and the CFR is getting down. That's my explanation. Thank you. Over.
I think it's pretty clear when you look, for example, at the experience of New York City, of New Orleans, Milwaukee. Part of the incredible fatality that we're seeing associated with COVID-19 is caused by the degree to which it exploits all the social faults that exist in urban America. It's heaviest, the mortality, in communities that also have high background rates of health disparities. So where you have a lot of hypertension, cardiovascular disease, diabetes, and especially obesity, you're going to see higher rates of mortality. Infection with COVID-19 that results in mortality does seem to be much more problematic for folk who are suffering from those conditions. Look at a city like New York, where there's incredibly heavy population density, where a substantial portion of the folk who are doing public-facing jobs are in the neighborhoods that have these background chronic disease conditions. Between exposures that occur on the job, being in densely packed neighborhoods where high rates of obesity, cardiovascular disease, diabetes happen to appear, means that once the virus takes hold, the level of fatality is going to be really extreme. Nowhere is this more evident than the United States. Than the rate of fatality in New York City, I think, is 76.2 per 100,000. I think in Hawaii, it's 0.8 per 100,000. What you're looking at is a very different way to understand the population structure of the United States and the degree to which this virus has exploited all the health disparities that exist in minority communities, so that the heaviest rate of mortality is there, most especially in the Black communities, nationally, and in the Black and Hispanic communities here in New York. So although there's a lot to be said about how fatal the virus might be from a medical sense, from a public health sense, the fact that it's in communities that are densely packed and the fact that there are so many ways in which the transmission can occur certainly accounts for the excess mortality that's associated with living in those kinds of communities.
I think this kind of an outbreak emphasizes how really useless the case fatality rate is with a virus where 80% of infections are mild or inapparent, and you can't hope to identify them all. The case fatality ratio depends on knowing the denominator of infections. And we can't possibly know that. And that's one reason, besides everything else that's been said, which is absolutely correct, another reason why we can't hope to know a crude case fatality ratio for this virus. We don't know the denominator. Now, with a virus like smallpox, where nearly every infection gives you clinical symptoms, clear clinical symptoms, there you can calculate that. But here it's almost useless. It varies by population. It varies according to the medical care. It varies according to the testing. And so in this pandemic, it has been touted as an indicator of the virulence of this virus. I think that's a wrong thing to do, because maybe in the end, as we really see how many people were infected when we do the serology, it's going to be less than 1% overall. And so I would be cautious about the case fatality ratio in such a virus with so many mild infections.
Thank you all for weighing in. I think there are definitely a lot of nuances and disparities involved in how different groups and countries have handled COVID-19. And I think this has also brought our attention to the fact that there are inherent disparities between different groups and how they're affected. So with that, we're going to be transitioning to a more of a public health, social sphere of the situation. And I would just like to pose a question, which is, how have narratives in the news and social media contributed to incidents of racism and xenophobia, and how do they perhaps play a role in COVID response? And perhaps Dr. Fullilove, and being USA-based, can comment more specifically on this, and Dr. Racaniello, also USA-based, can comment on how much medical truth there is to those narratives.
Well, I think the most problematic element of all is the notion somehow that the leadership in the United States, beginning at the White House, basically described this as the Chinese flu, the Chinese virus, the Wuhan.
Right.
Clearly that identified in the minds of the public somebody who could be blamed for what's going on. We have an unfortunate tendency in human culture to look for scapegoats. And I think what we're seeing right now is large numbers of people have lost their jobs because of this virus. Large numbers of people are struggling and are really wondering how their world has been so traumatically upset. And they're not really looking for scientific explanations. They don't want to know about the structure of the virus, and they don't want to know about the principles of epidemiology. What they want is somebody to blame. What they want is somebody they can point the finger at and say, you know, this is all because of you. We love in our television culture to have cops and robbers movies where we're finding the culprit, where somehow or other, as soon as you find the guilty party, the person who caused all this problem, everything goes away. It's the end of the show. The couple fades into the sunset. They ride off into the west. That's not how the way life works. We want to be focused on what we can do to keep people protected and safe. We want to make sure that the folk who are dealt the terrible hand of having to manage this epidemic are going to be secure in their positions. It's not about finding who is to blame. It's really a question of how can all of us who are suffering from the weight that this epidemic has produced, how can we bear that weight? And how can we join together to make sure that our society survives? I also worry about the fact that as it becomes more and more apparent that this is hitting Black neighborhoods very hard, that folks will start to think of it in the United States as a disparity disease. You know, it happens to them, so I don't have to worry about it. I worry that a lot of the pressure to go back to work is because people think it's happening in somebody else's community. Therefore, I'm not really vulnerable. So let me go back to work and, you know, worry about the folk over there because they're the ones who are suffering. A disparity disease gives people the sense that only some people are infected, only some people are impacted, and everybody else is going to be okay. That, I think, is the kind of thinking that will ultimately put us in real danger because we won't take the measures that are necessary with social isolation. And we'll suddenly find that we'll have second and third waves that are almost as bad as the one that we're going through right now. So I worry about the social implications, the social narrative that's arisen around this pandemic, and the fact that it's a very difficult narrative to confront and a very difficult narrative to defeat. I have my words, I have to admit.
Thank you.
That's a really interesting perspective, which I fully acknowledge, the desire to blame. You know, as a scientist, I blame the virus and it's causing this, but you're absolutely right. However, on a daily basis, I cannot fathom the fascination of the public with conspiracy theories, with lab creation theories, with accidental or intentional release theories that have zero merit whatsoever. And I think you're right that they probably just want to blame someone. However, it is driven by the political situation also in this country, as I'm sure you will agree. The desire of the higher administration to blame someone else for what is often their failings. So I think one of the issues in this one, and this is our first pandemic with an internet, really, a fully developed internet where news can travel incredibly quickly, and where all kinds of news, and we also have this scientific development of preprints now, which we didn't have before. And anyone could put a manuscript on bioRxiv or medRxiv, and the press immediately picks it up and spreads the news. It's on Twitter, and you don't even know if it's right. And guess what? Many of these are downright wrong. So all sorts of bad science gets propagated. And this is fed into the frenzy here of people wanting to blame, I think. And I don't know how to deal with this. I explain things to people. I explain to them why this virus was made in nature, and it's very clear, but still they want to perpetuate with these theories. And so I think something that has to come out of this pandemic, another thing besides the lessons I'm hoping, is how to deal with science. People, you know, often deal with politics, with economics, with social issues. Science, not so much, except in the time of an outbreak. And I think we're not good at dealing with it. And the press isn't particularly good at dealing with it either. I can't tell you how many people have come to our podcast recently and saying, I can't find good science on the news. I'm coming here. And we have to fix that, I think.
Thank you both for your perspective. Oh, sorry, yeah.
Yeah, I also want to make a comment. Like Vincent mentioned about, you know, this is a time you mixed the science and the public opinion together. So this is very dangerous. So we should leave the science to the scientists, leave the public opinion to the public. But once you mix those together, I do agree with Vincent's comments about, we ask all the scientists if they have any new results, put into bioarchive or medRxiv, whatsoever archive, to share the data. I think those are the data shared for the scientists, not for the public. And then because it's not peer reviewed, so all those must be peer reviewed. After peer review, you will know, whether or not those opinions is right. But now they just, any scientist, if you have a decent scientist, they would do that. If you have a scientist, it's a newcomers, they would, put any hypothesis there. And then the journalists pick up those hypotheses. There's no science, it's not science driven, not science based. And then it will spread in the public. Anyway, in general, this time, it's exaggerated. The problem with the so-called infodemic. We are facing both epidemic for the COVID-19. We are also facing a problem with infodemic. The infodemic, this is the word, I think by a journalist created during the SARS outbreak 17 or now 18 years ago. So I encourage everybody, the students, go and read a comment from MIT Technology Review published on February 6th. They claim, they are seeing something about this infodemic. The definition of infodemic is put or get the information and the misinformation zipped, pay attention to this special word, zipped together. So once you have all those information and the misinformation and the zip together, and then you have some explanation. And then, this is a second battlefield for us at the moment. I don't know whether or not the scientists really cares about, Wuhan virus, Chinese virus, or American virus. It doesn't matter what it's called. The problem is this virus is from the earth. So we are fighting for the virus. We are not fighting for, any countries or any personnel. So we are fighting for the virus. So anyway, so we should stay calm. We should, try to solve the problem of the virus, not any country or any, personnel. Thank you. Over.
Right. Thank you all for your perspectives on this. I think there's definitely a social and public amplification to this virus, considering our day and age, which can lead to a lot of information. So our last question in this section of the event is that people claim, and perhaps this is more angled towards Dr. Gao, and from the USA-based scientists, if you have any comments on this, you can also weigh in. But people claim that the statement, the virus came from China, is the truth and should be remembered. And that's definitely the way our President Donald Trump speaks of it. And if not, how do you think the public should view pandemics of foreign origins?
I already touched that question. I mean, we leave the origin of the virus, leave the understanding of the virus for the scientists. This is the scientific question. Leave for the scientists. The scientists will finally find out. It can take maybe by seeing that, after my seeing, you go back, some scientists already point out, here you go, this is the origin. Maybe it's possible. Maybe it takes years and years. And maybe we never have that answer. Because as I said, this is the virus on the earth. It's our common enemy. The enemy is the virus. It's not the patient or not for the country. So I think I would leave this one for the scientific question to be answered by the group effort, by the international collaboration of the scientists.
This virus came from nature, and as far as I know, nature has no country.
Yeah, because think about it, we just try to define the borders. And do you really think the earth, they have a border? This is Russia, this is China, this is America. Think about it, all the continent people you guys are from, maybe someone from Africa, someone from Europe, someone from China. China is the same. So anyway, I agree, Vincent, this is the virus from nature, it's not from the country.
I feel like I should weigh in. I think it's important to recall that the 1918 Spanish flu epidemic really began in Kansas. It was called the Spanish flu epidemic because there had been such a blackout about the pandemic in the US news, that when the Spanish king became infected, the first newspaper articles that appeared in the United States said, Spanish flu, because the Spanish king had it, the Spanish emperor, whatever title he had back then. So the idea that we have for more than 100 years misnamed the deadliest pandemic of the 20th century gives you a sense that, yeah, we do have to insist it's from nature, because we get the country wrong in ways that are completely not helpful, and give folk the notion that somehow its national origins have something to do with the level of mortality that's associated with it. Nothing could be further from the truth.
Right, right. Thank you all for weighing in on this. I think it's definitely true that the virus did come from nature, and that there's a lot of framing that goes into how people view these kinds of pandemics. So now we're going to be moving on to audience questions, because I've received quite a lot. The first one we have is, how will climate change affect the frequency and severity of the viruses we see in the future?
Well, climate change to me means getting warmer, and that takes away seasonality, which is really bad. So viruses in the Northeast where I live, there are many viruses like influenza, common cold, and other respiratory viruses that are seasonal and prevalent in the winter months. That seasonality will disappear. I don't know, there are warm climates which certainly have infections. So what that means for seasonality, I don't know. But my main concern about climate change is the expansion of the mosquito range. And mosquitoes carry many viruses and many dangerous ones. And Aedes aegypti is a main vector for those, and that range that currently is very limited. It's going to expand north and south, and those viruses will be delivered elsewhere. So I think we really don't understand the exact implications, but there will be changes in terms of where diseases occur.
Mm-hmm.
Yeah,
Yes.
Kathy. For this virus, Vincent comments very important for seasonality. From the very beginning, we thought it's a mild disease. And then we realized it might be a SARS. And eventually we realized it's, much dangerous than SARS, spread very quickly, and then you came out with a pandemic. And then people think there might be seasonality. And also might be, because of the, North Hemisphere and the South Hemisphere had the temperature, blah, blah. But now it looks like there's no evidence this virus spread has a seasonality. So if there's no seasonality, we are facing a more serious problem than seasonal flu. The virus will stay with us, and it's even serious than the flu. But we have to wait and see. As I said from the very beginning, this is a virus with so many hidden characters. We have to wait and see. From a current situation, my guess is there may be no seasonality. The temperature now in Africa and the temperature in China, temperature in Russia is totally different. And they still, the rate of the spread is still kept the same. We have to wait and change. Like also agree, climate change and all these factors are there. Over. Thank you.
As climate change moves populations around, population density, the trend towards urbanization, that's going to wreak havoc on the local environment in a wide variety of ways. It'll change the nature of biodiversity, which has a great deal to do with how nature controls the development of epidemics. I think everything about man-made change on this planet ultimately is going to have an impact on our health. And it's certainly the case that pandemics like this are just part of what I think we're going to see as a result of shifts in the way our environment is impacting our health.
Right. Thank you all for weighing in. So our next audience question is, can any of these specialists speak to the most likely time frame of the virus, if possible?
I think the one thing that public health people have been insisting is that we're very worried about people trying to get back to normal too quickly. Just because we're socially isolated doesn't mean that the virus is evaporating. So if it's simply resting in pockets and is waiting for an opportunity to emerge, it's quite likely that we'll have 1, 2, maybe even 3 waves before we finally see the end of our troubles with this particular pandemic. Interestingly enough, the 1918 influenza epidemic was one that had multiple waves. And a lot of what contributed to the coming back with some ferocity of that particular bug was the degree to which we just weren't ready to go back to normal. And one worries that although you might see a time when we'll start to come back to normal, many of us in public health are thinking that for some places it's going to be too early. There will be a rebound of the virus, and then we'll go back to something that might be even more draconian than the measures we've been undergoing now. I'm interested in how the other panelists are thinking about this, because I worry that it's going to be really hard to set a date, and it's not going to be a firm date, simply because we're going to be back in this mess again.
Okay.
And you already see, and we all have the resurgence, reoccurrence in China already, because of the imported cases. This is the pandemic. It's not just the war against the virus is in China alone. We got the virus down, and because of the lockdown and plus the mitigation, suppression, all these methods we use, it's a mixture. But China is not just a lockdown or containment; it's a mixture. And but if the virus still in anywhere in the world, the war is not over, and China we face an even more serious problem. At the moment that we have so many imported cases, we still have every day have 2 digits numbers of the cases at the moment. Mm-hmm. So we are working very hard, but as Robert said, we really need to think about when we should for the public health, when we should reopen our business. But if without business, what the human being is doing. So I think we have to do the balance between the reopen the business and the disease control. That's something we are playing at the moment in China. So we try to reopen all this business. We are working very hard to get the virus down. I think eventually we will find a balanced way. Thank you. Over.
Well, George, we're looking to China to your example to see if once you bring down the numbers, whether they come back or not by importation or other means. I think that's a really important example to set.
Vincent, you have to remember in China, before the imported cases into China, we already have more than 1 month. We have 0 cases, really you can get down to 0. And when you think about, I was told maybe in some cities or some areas, you are talking about 13% of serological survey, seropositive population, 30%. But in China, we did something, we are still working on it. Generally speaking, the herd immunity is not in China at all. Some areas, you even have less than 1%, i.e., the method, the strategy we introduced for the lockdown looks like it works. But the problem is this is a really special virus. And, the virus is outside of China is coming. Then eventually there will be another wave. It's local transmission. Thank you. Over.
Right. Thank you all for weighing in on this question. Our next audience question is, why do you think the rates of infection and death are so high in the United States compared to other countries?
I think we're very slow getting prepared. Our leadership failed us completely. I'm someone who spends a lot of time in France. I have colleagues there. Clearly, whatever else happened, folks paid attention to their public health leaders and said, we've got to do what we can to shut things down. We waited a very long time. We had, as Vincent has pointed out, years where we kind of knew this was coming. We had even organized committees to anticipate the day when we'd be faced with this kind of crisis, but that got disbanded. We didn't invest any money in building up an infrastructure that would allow us to get vaccine research underway and started. There are dozens of ways in which our fatality rate is so high, literally because we waited too long and did a terrible job of convincing the American public that it was in their best interest to socially isolate. As a consequence, I think you're going to continue to see super spreader events where it's not so much just population density, it's people getting together for church funerals, for weddings, what have you. Those are going to be the events that into the future are still going to provide the virus with all kinds of opportunities to expand and spread and find new populations. no question but that the problem that we had was not just that we weren't ready. We haven't done a very good job of convincing the American public that it is in their best interest to follow the dictates of docs and public health professionals and do what they say about keeping everyone safe and reasonably secure. I worry that we're very slow to learn key lessons, and we're about to pay for it.
First cases in the US were in Washington in January. You can bet that as soon as that virus was circulating in China, maybe November, December, it was already here. As soon as we saw that first case in Washington, we should have started extensive testing. We did not. It was already in hundreds and hundreds of people, I'm sure, after that first case. We could have picked those up, but we didn't because we had no top-down leadership. We had leadership who was denying that it was a problem. And that's why it's more extensive here. When New York finally shut down, we had to convince the mayor. A set of us virologists in the city wrote a letter to the mayor on a Friday. It wasn't until Sunday night that he shut down the schools. He wasn't going to do it. And this was already too late because there were already thousands of people infected. And so we could have prevented this for sure, but we were just too late. And that's why we have so many infections today.
Right. Our next question, thank you all for weighing in on the question, is a question for Dr. Racaniello. You mentioned that it is so hard to know what news is trustworthy anymore. So what is the best way for us to, for ourselves, what is information and misconceptions and what we can trust?
Well, in my view, when you're dealing with science, you should trust the scientists. Not every scientist, unfortunately, is trustable. You have to find the good ones. It's like finding a good mentor in whatever you do. It's really hard, but it's really crucial. And so I would say seek out scientists. More and more scientists are communicating. They're on social media, like me. They do all kinds of podcasts. They appear on the news. I think you have to seek them out and insist that your local news talk to scientists. I have very little control over what CNN and NBC and Fox do. I try and go on them as much as I can. But they have their own agenda, which is driven by profit as well. So it's very difficult. But on social media, the internet makes it possible for you to find a scientist. We get hundreds of questions a day about this outbreak, which shows you that the public wants to know. And so that's what I would suggest.
Right. Thank you. So our next question is, did the virus originally originate from animal to human?
George,
Yeah.
I think that's you.
Yeah. When you think about, it's all, when you are talking about the origin of the viruses, you are talking about the origin of the, say, I use could, countries. Of course, we already discussed this. Like Vincent said, this is the virus from the nature, the virus of the earth. And when you are talking about the species, when there's a reservoir species or intermediate species, all those must be based on the knowledge we know about any other virus. For example, flu, Ebola, Zika, all these viruses from our understanding, from a cumulative knowledge, because society is hard working, generations by generations. We know those kind of viruses, including COVID-19 virus, they are from animals. That's for sure. That's the knowledge. And the second, anything happen, there must be an origin. And this kind of virus, think about it, because SARS and MERS, particular coronavirus family, of course, they are from animals. And we also already know there are some viruses from either pangolin or bats. They are so close. I'm not saying the virus directly. You take great care of my expression directly. Maybe they are not directly from pangolin or bats. There must be some other animals. We believe must be a mammal because the virus came maybe from bat, and then bat is a mammal. But you need an intermediate host. It's so close, genetically so close to the human beings that this is why we think there must be one. Give scientists some time. They will find out for you. Thank you.
Thank you. Thank you. So our next question is, what do you think of the evidence-based inferential gap from the initial fact that there is no evidence showing that there is human-to-human transmission to the conclusion that we know that the risk of the virus to the general public is low? That was the question.
as I said earlier, from the knowledge, it's very difficult for you to rule out any coronavirus. It's not no human-to-human transmission because this is the coronavirus. Again, cumulative knowledge we obtain generation by generation. So we know that. So the only thing we need to find out, whether or not it's efficient or it's only, spill over from some animals you mentioned from origin, and then you have some limited human-to-human transmission. A good example is MERS. The MERS is you only have very limited human-to-human transmission. And the same for the flu. Avian flu, you have a very, very limited. And for this, I don't think we never see anything is a no human-to-human transmission. But the only thing is how efficient. Is it very, very limited? Is it limited? Is it spillover of human to human, or is it very, very efficient human to human? Now, look at what was going on with this pandemic. The COVID-19 virus adapted to the human very well, and you have a very efficient human to human transmission. Over. Thank you.
Okay. Then in that case, we can move on to the next question. Do you guys think that the next viral pandemic could occur between now and 3 years later? It seems it was very high on the National Intelligence Briefing, so that must be based on some data.
I think it's been very clear from your very first question when we opened this webinar that we have had a succession of viral epidemics, and they've been frequent enough and problematic enough to just assume that whatever is generating this wave of illness, it's going to happen again. What I think is impressive isn't just the existence of the pathogen, it's the arrangement of human settlement, human society, the manner in which we move about the planet. All of the features of modern life that make it easy for a pathogen to be transmitted are currently present. We're rapidly mobile, we're in communities that are densely packed, we have a lot of public-facing interactions which make it easy for folk who don't know each other to be in a position where they can transmit a virus infection from one person to another. Yeah, it's just inevitable that more than anything else, the manner in which viruses exploit crevices in the structure of human civilization means we will see them again, and we will see them often. Because I think this is one of the ways in which Mother Nature smacks us around for all the things that we've done to the planet since we showed up.
Right.
Yeah, I like to make a comment for the Mother Nature. So we got to respect the Mother Nature. To answer your question, Kathy, I do agree. Of course, we will have another one. Think about anybody working for the public health, working for the disease control and prevention. Like me, I'm the DG for China CDC. Once I said maybe we will have a SARS-like virus, we wouldn't have a SARS event. I was wrong. Why I was wrong? Because this definitely is not a SARS. If you have another one like COVID-19 in the future, definitely we might be able to do something better than what we are doing now. I mean, say I was asked a question like this from time to time here in China. If you think about it, if this were a SARS virus, we already finished the job. We won the war already because China introduced the containment or lockdown in Wuhan everywhere. And for 1 month in China, we didn't have any cases. But this is not a SARS. So in my opinion, eventually we have another one. It's not SARS, neither SARS nor COVID-19, something else. The virus will behave differently. So the only way we can get rid of this dangerous pandemic, respect to our Mother Nature. Make sure we love the earth, we did our right job, we behave ourselves. So make sure you are not doing something against our Mother Nature. Ecology, climate change, okay, behave ourselves. Over. Thank you.
Thank you. Okay, so we have one last question. How should we react to skepticism in the news towards test results and suspicions that they are underestimates?
We should accept that as the truth. Last week, the fatality rate in New York City jumped by a couple of thousand because we finally counted as part of the COVID-19 mortality all the folk who died at home, all the folk who were unable to get a diagnostic test that confirmed that they had COVID-19, but where there was ample suspicion that that was the cause of death. So there's no question but that we've had to really struggle to sort of figure out, as Vincent said, how large is this really? How many people are actually infected? What's the actual mortality rate? Because again, as he said, we don't know the denominator. It's really hard to figure out ways in which, amongst other things, the test results we get are so reliable that we make accurate judgments about whether or not, for example, we should go back. I think there's no question that all the modelers suffered a bit of a blow in the United States when instead of having 200,000 deaths, we've had substantially less. So that's led a lot of people, skeptics in the general public, to say, see, y'all don't know what you're talking about. Y'all really don't know how to do these counts. So whenever you tell me that I should wait until December, no, I think you were wrong about mortality rates. You're probably wrong about when we can go back. So there is a lot of skepticism that is fed by the difficulty in pinpointing precisely how many people we're talking about who are infected and how many of them are likely to progress to a state where they have to be hospitalized or, God help us, die. Until we know that accurately, people are right to sort of really question whether or not the numbers that they're seeing are accurate. And it's one of the reasons why figuring out what's the best indicator to make sure that we're free and clear of all this is still something that we're in the process of debating.
What this tells you is that in the middle of an outbreak of a brand new virus, testing is very iffy, whether it be PCR or antibody-based. They're all being developed on the fly. It's hard to regulate them. I'll tell you what you can depend on. In 2 or 3 years, the serological studies will tell us exactly the extent of this outbreak.
Yeah, we'll be able to have some sense of how many people have antibodies that are clearly a result of exposure to COVID-19. But for the moment, specificity and sensitivity, the things that we rely on with our tests, they're just missing. False positives, false negatives. I mean, I think people are right to wonder whether or not the counts that they're getting are really accurate. And Vincent's point about case-based ways of doing estimates, now it really doesn't work. There's too much variability in who dies and under what circumstances for us to assume that case by case, we have some sense of how this is really progressing. So skepticism is, I think, something that we all work with, as long as a sense of optimism that at some point in time, we really will get on top of this and we'll have a way of managing it better than has been the case thus far.
Okay, and with that, we have reached the end of our panel event. I'd like to extend a huge thank you to all 3 of our panelists, Dr. Racaniello, Dr. Fullilove, and Dr. Gao, for extending their time today. We've definitely all really learned a lot about the situation and have a lot to think about about COVID-19 from a medical, socio-medical, and public health perspective. I'd also like to give a shout out to my team over at CSR for helping me design this event, Nguyen and Boyuan Chen. Thank you so much for being here today with us. Thank you all for coming. I think we definitely have a lot to think about. And good luck, everyone, and stay safe and wear a mask and sanitize your hands.